And I'm delighted to welcome you all here today to find out about a quite extraordinary public health modernization assessment that we're going to look about and talk about what comes after this. I think we ask the people on the phone to put their phones on mute, please.
Please, all participants are now in listen-only mode.
We've got you on listen-only mode, so it's a little quieter here. This is quite an extraordinary process that we're going to talk about today. It came out of an assessment in the state legislature that while we were spending billions on modernizing the medical care system, most of what affected people's health did not happen in a doctor's office, but it happened somewhere out in the community. The recognition also was that most of the citizens of the state of Oregon were not necessarily in a place where they had access to modern foundational public health services, such issues as protection from environmental hazards, protection from communicable disease, emergency preparedness, and other kinds of things that could affect people's health. A task force was put together that produced a report underlying this. The task force was chaired by Commissioner Tammy Bainey of Ben and staffed by the Public Health Division. All right. Am I okay to talk now?
Good to go.
Let's go. You're going to hear about this quite remarkable assessment that's going to lead to the modernization of Oregon's public health system. And I find it really quite extraordinary where we are and where we're going. So hang on. Senator Monis Anderson.
Great. Thank you, everyone. Good morning. I'm Oregon State Senator Lori Monis Anderson. I'm from I represent District 25, which is East Multnomah County, Gresham, Troutdale, Wood Village, and Fairview. And thank you for joining us today to learn about how we'll be moving forward as a state to modernize Oregon's public health system. As a former public health nurse, I worked for Multnomah County Public Health and Clackamas County Public Health. And there were a range of differences between the counties, including the amount of money for public health services. It is so important that we're going to be protecting everyone in this state. And I was pleased to serve on the Future of Public Health Task Force along with Representative Greenlake in 2014. And there has been a tremendous effort and consideration on behalf of the Legislative Assembly and our partners to craft a public health system that works for Oregon. Public health provides a foundation for improving the health of everyone in our state. As a former public health nurse, I know that Oregon's public health system works tirelessly every day to keep communities safe and healthy. I don't know how many immunizations I gave. I don't know how many follow-ups from communicable disease outbreaks that we have had, but all of those are critical to keep Oregon residents safe. A modern public health system will enable every community to provide essential prevention programs and respond to emerging health threats. Investing in those public health programs is critical to the health of all people in Oregon now and for future generations to come. I'm hoping that you'll share your ideas and questions this morning so we can work together towards a modern public health system. And I would like to know if there are any representatives or senators on the phone, if you would introduce yourself or staff.
All participants are now in interactive talk mode.
Are there any senators or representatives or staff on the phone? All right, thank you very much.
To begin with, why does the public health system
To
need
place, all participants are now in listen-only mode.
and why now? Briefly, in the last 16 months, the Public Health Department, in collaboration with public health departments across the state, has managed a global Ebola outbreak, a Zika outbreak, a meningitis outbreak, the crisis and tragedy in Douglas County at UCC, and the challenges of Kearney County. That's in just 16 months. In 2016, state and local public health authorities completed an assessment of our existing public health system, which we'll hear about in detail shortly. Through this comprehensive statewide assessment, we found that more than a third of Oregon communities have only limited or minimal foundational public health programs. For environmental health, the Public Health Modernization Assessment found that identification and prevention of environmental health risks are limited or minimal in 2/3 of Oregon's communities. In light, again, of recent events across the state, lead in school drinking water, radon exposure in schools, metals emissions from manufacturers, air quality concerns, investing in environmental public health is a critical protection for all communities in Oregon. A modernized public health system will be in environmental public health planning, collaboration, and monitoring to protect all people in Oregon, especially those at highest risk. Environmental health issues such as childhood lead poisoning, poor air quality, and the health effects of climate change disproportionately affect low-income and minority populations. For communicable disease, the Public Health Modernization Assessment found that 1 in 4 people in Oregon lives in an area where communicable disease control programs are limited. Our public health system plays a critical role in preventing the spread of emerging diseases like Zika, like Ebola, and managing outbreaks like meningitis. Preventing the spread of communicable disease will prevent deaths and improve health, and a modernized public health system is critical to ensure there is capacity across the state to protect all Oregonians from communicable disease. We could go. There we go. Thank you. Currently, the availability of public health services depends on where you live in Oregon. This is in part because our public health system relies heavily on federal categorical funds and county general funds, which vary from county to county. In my travels across the state in the last year, many counties have said to me, we have one person trying to meet the entire needs of the public health system in our county, and it's simply not sustainable. At the same time, our public health system was originally designed to provide access to safety net services for individuals who are uninsured, sometimes at the cost of supporting population-wide programs. With more than 90% of Oregon residents now insured, Oregon's coordinated care organizations are well set up to be able to provide clinical services to our Medicaid members. This allows the public health system to be able to focus on population-wide interventions that are a foundational part of Oregon's health system transformation. Currently, we have 1.1 million citizens in the Medicaid system, and we have 3.9 million systems overall. Oregon is the envy of many states in that our public health operations and our Medicaid services are all under one agency, which gives us the ability to integrate those systems for maximum effect and benefit to Oregonians. What public health modernization aims to do is provide an essential level of public health programs for everyone in Oregon, regardless of whether you live in a small town, a big city, or east or west of the Cascades. In order to do this, we need to have the infrastructure to allow us to focus on the needs of Oregonians, and finally, we can build a 21st century public health system that is accountable for the health of the community it serves. The concept of public health modernization is not new, and rather it continues our path towards achieving the triple aim. Oregon's Action Plan for Health, a founding document developed by the Oregon Health Policy Board in 2010, called for a robust public health system as a critical component of the health system working to improve population health.
So how did we begin our journey? As we've heard, the concept of modernizing Oregon's public health system began in 2013 when the Oregon Legislature passed House Bill 2348, which created a task force to develop recommendations for a public health system in the future. The task force on the future of public health services consisted of a committed group of state legislators, leaders in nonprofit organizations, local public health administrators, a county commissioner, and other stakeholders. The task force met for 9 months in 2014 and submitted its recommendations for a modern governmental public health system to the legislature in September of 2014. The Modernizing Oregon's Public Health System report included the following recommendations. The foundational capabilities and programs for governmental public health should be adopted. The task force recommended application of the National Foundational Public Health Service model to Oregon, and that was derived from the National Institutes of Medicine. Foundational capabilities and programs are those things that every health department must provide across the state. Secondly, significant and sustained state funding should be allocated to public health. Recognizing that Oregon's current public health funding would not fully cover all of the foundational capabilities and programs, this task force recommended the addition of new state funding for public health. Thirdly, implementation of the foundational capabilities and programs should occur in waves over time, taking into consideration that modernizing Oregon's governmental public health system will be a multi-year endeavor. The task force determined that implementation by waves over a period of time is likely to be the most successful in really transforming in a sustainable way our public health system. Local public health should have the flexibility to operationalize the foundational capabilities and programs in the new structure. One charge to the task force in developing its legislative recommendations was the exploration of regional public health structures. The task force recommendations offered 3 possible ways to achieve that local public health authorities might implement the foundational capabilities and programs, either as a single jurisdiction that shares certain services with others, or through the formation of a multi-county health district. And last recommendation was that improvements to governmental public health should be structured and measured around quality metrics established by the Public Health Advisory Board. The task force recommended that a new oversight body for governmental public health in our state, the Public Health Advisory Board, be enhanced to take on a greater role in modernizing Oregon's public health system. As part of this work, the Public Health Advisory Board would be responsible for establishing quality metrics for both state and local public health authorities. The model developed by the task force in the conceptual framework for governmental public health services is a description of the foundational elements of governmental public health. It's the role of governmental public health through the combined efforts of both state and local public health in collaboration with coordinated care organizations, community partners, and others to assure these functions that they happen in local communities with the input of people and local communities. Public health maintains a population-wide perspective on improving, protecting, and monitoring the health of everyone in Oregon. Foundational capabilities are the knowledge, skills, and abilities that must be present in order for these foundational programs to be successful. Foundational programs drive us to long-term health outcomes, and additional programs are available in communities based on the local needs of that community. House Bill 3100 was the result of the Oregon legislators using the Modernization of Oregon's Public Health System Task Force report to draft House Bill 3100, and this was signed into law in July of 2015. House Bill 3100 operationalizes the task force recommendations we just discussed over the 2015-17 biennium. In addition to adopting the task force recommendations, House Bill 3100 also called for the development of a public health modernization assessment, which we will share the findings with you this morning. So where are we on our journey? Since House Bill 3100 passed in July of 2015, Oregon's public health system has been working to accomplish the provisions of the bill. This included the development of a detailed set of definitions for each foundational capability and program for both state and local public health authorities. These definitions are compiled in the Public Health Modernization Manual. In order to establish leadership for public health modernization, the Public Health Advisory Board was appointed by Governor Brown in December of 2015. The Public Health Advisory Board began to meet regularly January of 2016. Between January and April 2016, both state and local public health authorities completed a robust public health modernization assessment designed to identify what the public health system is currently providing compared to what is included in the modernization manual and what resources are needed to fully implement public health modernization here in Oregon. We're here this morning to provide you with an overview of the Public Health Modernization Assessment Report, which was submitted to the Legislative Fiscal Office in June, that helps to fulfill the initial deliverables for the Oregon Health Authority in House Bill 3100. A report on the estimated health outcomes and cost savings attributable to public health modernization is currently underway and will be released in September. Finally, the Oregon Health Authority, per House Bill 3100, will complete its initial public health modernization plan by December of this year. And at this point, I want to turn it over to Michael Hodgkins and Annie Sauerwein with Burke Consulting to provide us with an overview of the specific findings from Public Health Modernization Assessment. Annie? Oh, Michael and Annie.
Yeah.
Okay.
Thank you. I'm going to do a little bit of lead off and then turn it over to Annie, who did all the real work. So a little bit about us. My name is Michael Hodgins. I'm a principal with Burke Consulting. We're a Seattle-based multidisciplinary policy analysis consulting firm. We've been working in the Northwest across a wide range of public service areas for more than 25 years. Our particular focus is really bringing really rigorous analytic work to support policy analysis and policy development. And so in this, it sort of lined up very well with the specific task that we were brought in to help with here on Oregon modernization. In addition, the last 3-4 years, we've been working in this same area in Washington. So Washington, in that work, we were able to do some of the very first work around cost analysis for this concept of foundational public health programs and capabilities. So we were able to take a lot of that work and sort of bring it into help sort of frame up and do some of the pretty rigorous analysis that was required in this assessment on a fairly short time frame. And it worked really well because what we were able to bring was some really detailed knowledge of the concepts that both Washington and Oregon are working with around modernization, as well as initial findings that we had in Washington, which has a very similar service delivery model to public health, and marry that up with a very robust process of engagement with local public health and state public health practitioners and stakeholders to bring that local knowledge and perspective married up with some of the technical expertise that we were bringing. And so we were really able to hit the ground running. We got on board in late 16, so about December 2016 when this process really got going. And what we were able to do is in conjunction with the state and the local health stakeholders, really develop a very comprehensive and detailed assessment that really took some of the work here to a whole other level. And so that's what we're going to share some of the preliminary findings with you today. I'm going to have Annie Sauerwein kind of walk through our findings. As I said, she did a lot of the heavy lifting here. And so Annie, can you take us from here?
Thank you, Michael. So our assessment was really intended to answer 2 key questions. The first question was the extent to which Oregon local and state public health authorities are already implementing and providing the public health modernization services. We had the benefit of the Public Health Modernization Manual, which really outlined the services that are expected as part of this new framework. And so we were able to leverage that as our programmatic framework to really help folks provide kind of self-assessment of the extent to which they've implemented those services. The other question we were asking was really around what resources are needed to reach full implementation, and with that, the extent to which they're already spending resources to get to the level of implementation they are at today. So the first question being our kind of full implementation cost question, and the second being the current spending question. What we've done in the assessment is we've provided detailed information that we collected from all 35 state and local public health authorities to provide a picture for each foundational capability and program, as well as some intermediary functional areas, which are kind of the operational activities under each foundational program and capability of level of implementation. And what we've done is I've shown an example here for the foundational program environmental public health to give you an example of how we display that information. And so what you'll see is under state activities, which are quite different from local activities, we've provided the state authority, public health division's level of implementation. And you can see here that for environmental public health services, there is limited implementation at the statewide level. We've also provided this for local activities, and we've used the level of implementation from each local agency and used their service area, the population they serve, to demonstrate the level of implementation across the population. And so what you can see here at the top bar is for environmental public health, almost 90% of our residents here in Oregon have at least partial implementation of overall environmental public health. What's interesting here is that we've also provided functional area level of implementation, so you can see that when you look at this from an activity standpoint, there are some activities that are much better implemented than others. And so the example here is conducting mandated inspections. That really meets our expectations because mandated inspections are somewhat funded because they're supported by fees. But you can also see that we have a huge programmatic gap in identifying and preventing environmental health hazards. And that really speaks to us because we know that Oregon has been facing a number of challenges in identifying and preventing environmental health hazards. And so we can see that there may be a programmatic reason for that. And so the assessment findings are very helpful in identifying where these gaps live. And then we can also overlay that with our cost information to understand how to fill those gaps.
Just wanted to maybe add a couple little things here, which is, I think Annie covered this, but I want to maybe emphasize that this is really the self-assessment of these organizations. And so the Modernization manual has a lot more detail than obviously what's up here. And so it describes a long series of roles and responsibilities, deliverables, really the expectations of local health departments and public health division in terms of what it means to do these things. And each department and the state went through and did their own assessment of how much of this and to what degree some of these things were being done today. And so that base of information is what kind of rolls up to this, but it actually goes, as you see in the report, it actually goes quite a bit deeper in terms of some of those individual roles and responsibilities as well. But even at this level, you can kind of start to see that some of the gaps are really within certain elements of environmental public health, not necessarily overall. And so that's again where this detailed assessment was particularly valuable, because you can go quite deep and then roll back up and kind of sort of find those key sort of high-level sort of structural and programmatic gaps in terms of how to think about starting to move the state forward through modernization.
We're going to show this picture collectively as well. So what you'll see here to orient us to the graphic is that vertically we have listed the programs and capabilities. So at the top we start with communicable disease control, all the way down to the bottom, which is the capability, leadership, and organizational competencies. Across the top we've listed the actual state and local public health authorities. So each column represents level of implementation across all 11 programs and capabilities for each state and local agency. On the left-hand side, we have Public Health Division, and then we move from our extra large agencies all the way down to our extra small agencies. We provided these results anonymously to protect the results from each local public health authority, but each of those columns presents a picture. And what the collective picture allows us to see is that there's a lack of evenness in implementation across the state. So there are programmatic gaps in every foundational capability and program, but where those gaps exist is different across local public health authorities. And there aren't clear patterns in terms of geography or size of agency or anything of that nature. So you can see that there's several gaps. Just to orient a little bit further, dark blue and light blue are closer to full implementation. There's significant and partial implementation respectively. Orange is really our least implemented. So you see minimal implementation where we have orange. So those orange and tan are really where our most significant programmatic gaps exist at this point in time.
Right down the list on the left, quickly, what those
Sure.
programs are.
Communicable disease control at the top, environmental public health, prevention and health promotion, access to clinical preventative services. The capabilities start after that with assessment, epidemiology, emergency preparedness and response, communication, policy and planning, health equity and cultural responsiveness, community partnership development, and then at the bottom, leadership and organizational competencies. So the assessment process was very valuable. The first thing I'd start by saying is that we also started this process with an unevenness in terms of understanding of the programmatic or the public health modernization framework. So we were really able to build a shared understanding. So it helped us to reinforce kind of a consistent interpretation of that framework, which will be very valuable to implementation because the whole point of this work is that there's a need for a foundational level of service across the state. And so we're starting to build a shared understanding of what that really looks like at individual local public health authorities and at the state level. It is important to note that the work that was done for this assessment was really done under the current funding and service delivery paradigm. So we used current spending and subtracted that from full implementation to really understand the additional increment of cost needed. But if current spending were to change significantly, that could mean that the additional increment of cost needed would change as well. And so it's really important to understand that. The other thing is that we have a current service delivery model here in Oregon that has kind of a split in state and local activities where state activities are provided by one agency wholly centrally here at Public Health Division, and local activities are provided very locally by local public health authorities across the state. That isn't the only potential service delivery model, and so there is a need to continue exploring opportunities for cross-jurisdictional sharing and cross-jurisdictional delivery, which we also heard about a little bit in the task force report. Breaking out of these paradigms is going to take some time though, and we really think that that's part of what will evolve as implementation progresses, which will have the benefit of allowing us to learn from implementation and continuously improving as we go. Part of this assessment was also to understand what our programmatic findings mean in terms of the cost of implementing this at the current point in time. So this provides a preliminary point in time kind of planning level estimate of what implementation would take under the current public health system with the current funding and service delivery paradigms. What we see is that we are currently spending about 2/3 of what it will take to reach full implementation annually. So annually, about $209 million is being spent on foundational public health services, those 11 capabilities and programs. That leaves a significant funding gap. So there is a preliminary annual kind of additional increment of cost needed to reach full implementation that we've estimated at $105 million. Again, we think that this cost estimate will continue to be revised as efficiencies and new opportunities to increase effectiveness in the governmental public health system are identified.
Yeah, just to reiterate that last point, this is, again, in a hypothetical world where if all of this could be done immediately, and how would local health departments in the state ramp up to do this? Clearly, this is going to be phased in over time, and so there'll be opportunities to learn and evolve as we go. But as Annie said, this is sort of the snapshot, is if we could snap our fingers and all local health departments and the PhD could sort of step up and do this. This is the estimate of what it would take.
One of the other really interesting findings from the report is that there are significant interdependencies in the roles and deliverables outlined as part of public health modernization. So we've identified that there's service dependencies between the state and local activities, which will be very important to planning implementation. For example, Public Health Division supports many of the statewide assessment, databases and a lot of the data that's used by local public health authorities in writing their community reports and assessing where they are at. The local public health authorities can't do that work if that state database isn't being updated or doesn't exist. And so it's going to be really important that we're thoughtful and recognize that nuance in how implementation is phased in order to make implementation as efficient as it possibly can be. The other thing to recognize is that many of the foundational programs and capabilities also support each other. So our cross-cutting capabilities support a lot of our programmatic work. And I think the most intuitive example is educational communications, which plays a huge role in supporting tobacco prevention work, as well as healthy eating, active living work. And so we want to be cognizant that those communications and other capabilities are needed to support programmatic work, which may look like it has the greatest health impact, but really does that on the backs of some of these cross-cutting capabilities. As we've mentioned a few times, this is the first step in what we expect to be a very quickly evolving process that you'll have the benefit of refining as you implement. So there's a need to continue exploring some of the things that we've identified in this assessment and some things that the local public health authorities and state agency have really identified as priorities. Service delivery is one of the most obvious things. That's a place where efficiency and effectiveness has the opportunity to continue to be increased. And so cross-jurisdictional sharing as well as cross-jurisdictional delivery should continue to be discussed, and opportunities to implement more sharing should be considered. We also think that there's partnerships that need to be leveraged, and I think Lillian and Lynn both did a great job of introducing how public health fits into the overall health landscape, and so continue to identify that and figure out what roles other agencies might play in public health modernization will be important. The other thing to identify are any barriers to implementation. So if there are things that would prevent implementation from going as smoothly as it could go, those are things to continue to identify. As all of this work is done, we should continue to refine the estimated cost of implementation and the additional increment of costs needed. That is something that we think will have to be updated as progress in implementation is being made and as any changes to the service delivery model or funding model are made. Implementation will be a significant undertaking. I don't think anyone thinks that we are going to staff our figures and have this happen over time or overnight. And so we do want to think about how we might phase it in the most appropriate way. If it is phased over a multi-biennium period, there's decisions about how to phase. And what I've done here is I've put in our graphic that shows the unevenness of implementation. And one way you can think of implementation is how the annual dollars that you put into the public health system will change this picture over time. Waves are a thought that has come up, and that would change this picture in a really specific way, starting with a few agencies. But there are a lot of other more flexible ways to think about implementation. And this picture provides a good way to think about how those implementation decisions will have an impact. A flexible implementation strategy is really needed here, and so what we've suggested from the assessment is a flexible decision-making framework that would allow those decisions to be made over time and for learning from implementation to be considered. We recognize that there are going to be tensions in any of the criteria that you use in a decision-making framework. And so that really is where Public Health Advisory Board and other stakeholders should be consulted in determining how to apply such a decision-making framework. So that concludes our presentation, and we'll move over to Jeff and Zeke.
Great. Good morning, everyone. I'm Zeke Smith, the chair of the Oregon Health Policy Board. Glad to be here. And want to quickly introduce Jeff Luck, the chair of the Public Health Advisory Board, and give you an opportunity to hear from him. We've both been asked to share a little bit about kind of next steps in the process. So as I think about the story at this point, the legislature in the last session set some clear definitions around how we think about the public health system with the foundational priorities and capabilities, put in place a new public health advisory board that reports to both the health authority and the health policy board, and has been responsible for then accepting this assessment. So taking that information and now thinking about how to use that information to begin to think about some of the flexible decision making as we look at scaling up services across the state in an equitable way. So Jeff and I want to share a little bit more context about both that process and what they've been doing as an advisory board, and how you can expect some of that information to be coming to you all as a legislature. So there were a set of criteria that the Public Health Advisory Board put in place and that the Oregon Health Authority used to identify priorities for the public health modernization process based on the assessment findings. The criteria that they established are population health impact, which is the degree to which meaningful improvements in health can be expected. Service dependencies, the degree to which the Oregon Health Authority is dependent on local public health authorities to implement a specific function, and then the reciprocal relationship with the state. Equity, the degree to which underserved areas or populations of the state can gain access to a critical public health program. And then population coverage, the percentage of the population receiving a public health program. So as the committee or the advisory board has been looking at the foundational elements, these have really been the criteria that they've established to think about how you would prioritize additional investment across the state in an equitable way. The assessment demonstrated, as you saw, that there are significant gaps in the public health system's current ability to meet foundational capabilities and programs in all areas of the state. It's pretty clear that local health authorities have had to make decisions with limited resources and significant needs, and those decisions have been localized, so they've looked really different in different parts of the state. And I think part of the question for all of us is how do we, if we're going to make some additional investment in public health, how do we do that in a way that both meets critical needs but also recognizes the degree to which those decisions need to be localized consistently based on the fact that they look so different in each of those communities to date. So using those criteria, the advisory board really has said these are the priorities that they would identify for the first phase of public health modernization. So again, considering this idea that there's a $105 million gap based on the assessment, and as we look at the kind of phasing of implementation, in the first phase, these were the 6 capabilities and elements that stood out for the advisory board. Communicable disease, detecting and responding to traditional and emerging infectious disease. Think Zika, which is an odd thing for someone named Zeke to say, but I did. Environmental health, limiting environmental health risks to human health. In particular, we've seen this come up significantly in the recent past as localities are dealing with water issues and air-based issues. Emergency preparedness, there was the recent Cascadia experiment or experience and clarity that there are significant needs in the state around natural disasters and other catastrophic events. Health equity, I don't think I need to tell you that we continue to be a state where inequities are significant, both based on localities and based on population by race and by poverty. And then a focus on population health data and public health modernization planning, so both of which become really foundational and critical functions that the state and local health authorities have to work together on to ensure that we have clarity about how we're actually making progress on outcomes, and that we have the infrastructure in place to really support the work that needs to be done. So the current recommendation from the health authority is a $30 million initial investment in this 2017-19 biennium. So that is a recommendation for $30 million over the biennium to begin implementing the priorities. As we heard earlier, the annual gap is $105 million. This initial investment is designed to scale up over time as additional public health modernization priorities are phased in. These resources would go directly into the community to improve the health of everyone in the state. And this initial investment would be used to enhance public health leadership and the public health workforce to become more able to meet new public health challenges, to meaningfully improve health equity through partnership with communities, to provide comprehensive data on population health in order to inform decision-making, and to support communities in mounting timely responses to emergency issues, including environmental health hazards, communicable diseases, and natural and man-made disasters. So really beginning to implement on those 6 prioritized foundational areas. So if you look at the framework that was identified by Lillian earlier, and you can see highlighted here the areas that are being identified for prioritization, both in terms of foundational programs and foundational capabilities. I think part of what's important here is to recognize, as you see in the assessment in real depth, is the difference between how local public health authorities have been able to currently invest in those different areas. And so there is still this flexible decision-making that's being recommended across the system. And then lastly, in terms of my part, I think it's worth looking at where we fit nationally as we think about public health investment, which in some ways reminds us of how acute a reality it is that we have not invested effectively in public health in our state. So this graph shows you our 3 neighbors, one to the north, one to the south, one to the east, 3 of our neighbors, I should say. And you can see that we fall far behind those 3 states in our state per capita investment in public health. We're 31st nationally. The national median is $33.50 per capita. We're at $26.60. Another way to think about this is, as the whole health authority was putting together the request for the recommendation for $30 million in the next biennium, is that that represents a $15 million additional annual investment in public health, which would bring us to roughly $30.35 in state per capita funding. So still below the national median, and still below our neighbors, but beginning to start to make a difference as we think about investment as a state. So just gives, I think, some clear understanding of where we sit and why this is really important, relevant, and timely information at the time. Jeff?
Thanks, Zeke. So I'm going to speak just very briefly about some ongoing implementation activities being undertaken by Oregon Health Authority, Public Health Advisory Board, and the Coalition of Local Health Officials. But I would like to acknowledge the intensive and thoughtful work of all the members of the Public Health Advisory Board over the past several months. Several members of the board are with us in the audience today, so thank you all for joining us today and working so hard over the last several months. So House Bill 3100 required the development of a formula to ensure the equitable distribution of any incremental state funds to support modernization. And as Zeke alluded to, the Public Health Advisory Board and OHA have considered a variety of criteria to include in this formula, which will be used to allocate any incremental funds across local health departments. So the first 3 criteria shown on this list, population size, disease burden, and health status, are actually required in the legislation. And the other 3, racial and ethnic diversity, poverty, and limited English proficiency, are being considered to incorporate health equity into the formula. So over the coming months, we will finalize the specific criteria, the data sources for each one, and the weighting of each criterion in the formula. The formula also has to include a way to allocate matching funds to encourage increased local county investment in public health, as well as a quality incentive pool. Next slide, please. So that quality pool, as Lillian, I believe, mentioned, requires that there be incentives to encourage the effective provision of public health services. So we've talked about both equitable and effective provision of public health services. So the Public Health Advisory Board has been working to identify a set of public health quality measures that can be used to allocate this incentive pool. At this point, the The criteria for selecting measures have been finalized, and FAB is reviewing potential measures. To the greatest extent possible, we plan to select measures that align with existing measures, such as in the State Health Improvement Plan, national initiatives like CDC's Winnable Battles, or measures already used by Oregon's CCOs or early learning hubs. And finally, Oregon is one of 3 states that's received funding from the Robert Wood Johnson Foundation to support implementation of public health modernization. This work is being led by the Coalition of Local Health Officials. The first activity under this grant is a series of about 10 regional meetings throughout the state, and that will allow elected officials, CCOs, early learning hubs, community-based organizations, other stakeholders to come together to learn about public health modernization and provide feedback on how to implement it locally in their communities. So these meetings are planned for September of this year through January of 2017. And second, during the year following the grant through February 2018, technical support will be provided to local health departments as they prepare the public health modernization plans that they'll be required to submit. So we really appreciate the legislature's support for public health modernization. We appreciate your attending this morning's briefing and hope that you or others you know may be able to attend the meetings in the regions you represent. Thank you.
So I've been given the unenviable task of trying to moderate some level of discussion in a very short period of time when there's been a massive amount of information that's just been thrown at you. So I will do my best to do that. As
To
Jeff
place
just
all
alluded to,
participants are now in interactive talk mode.
we are all now in discussion. There are a number of places in the coming months to engage in this discussion, both from an input standpoint and also from a position of making some decisions. That's both with the Public Health Advisory Board. We will also be taking up these issues at the Health Policy Board, and then clearly the legislature will have some opportunity to engage moving forward. So I just want to acknowledge that there is more opportunity for engagement, but there's been a lot of information thrown at you, and this is what's designed as a briefing for you all as legislators and legislative staff. And we wanted to provide some opportunity for you to both potentially share kind of what you're thinking or what's kind of come up in this conversation, but also to ask some questions. If we have an opportunity, which we may not, beyond the legislators and legislative staff, then I will potentially open it up to additional discussion from other individuals who are here. But I also have one last responsibility after managing this discussion, which is to hand it back to our hosts in Senators Anderson and Representative Greenling. So I will make sure we do that and still get out of here on time. But with that, are there any questions or thoughts from folks, legislators or staff? Representative Kenny Geyer.
Thank you. This is on. Hello?
There you go.
Hi. Thank you. Thank you for the leadership of Representative Greenlick and Senator Anderson on this very exciting. I've been privileged to be in the Healthcare Committee and hearing it as it's unfolded in the last few years. And thank you to all of you who have been a part of this. I have 3 questions that are kind of related, so I'll throw them out there. One is why 30 million out of the 105? 30 million is a biennial number. The 105, I think, is an annual number, so that's a pretty small percentage, 1/6. Are the barriers just revenue source, or is it also you have a timeline for how you can ramp up in terms of the workforce and other people that might be a part of this? Secondly, how much of the 30 and the 105 is devoted to county personnel versus state personnel? And third is, have you looked in trying to decide the 30 and trying to designate state versus local, what the return on investment is? And I just got back from Denver on the Winnable Battles with CDC with Karen Gerard from your Public Health Department, and I know others were calling in as well. And they have a lot of modeling for a lot of the things that's on your wheel. And so I'm wondering how much, and they can do more, they put that out there if we want more modeling, but I wonder how much that played into where you decided to put that 30 million. And how you designate state versus local.
Thank you, Representative Kenny Geyer. We are in the process right now of the the policy option packages and the preparation of our budget. We've had round 1 of those meetings internally. Round 2 is next week. And so preliminarily, I can't tell you today the allocation between counties and state. There's a discussion following round 1 of questions that I asked about how that process is done. We are very mindful of the pressure on county departments currently and are going to look at that number again. We are going to use the winnable battles discussion information that we got from the conference and looking at how we spend these monies. I think and Lillian can respond to this further as well, I think initially we're very much looking at this as phased work, and so we thought this was a good starting point. The $30 million was a good starting point for the next phase. But again, our assumption is that not only would we not have the workforce, but right now, having just gotten this information, we don't have the work plan to go forward with a larger ask. We're wanting to be very responsible and prepared in what we're asking for. So we have more work to do, and this is going to guide that work as we go forward. I do want to add, and I'll turn it over to Lillian, is as we all know, we have 9 tribes in Oregon. They are sovereign nations. We've had a preliminary discussion in an official consultation with them about the public health department work. It is obviously critical to their people that the work they're already doing be recognized, and the work that needs to be done on the reservations also be recognized. So that will be a next phase step. I think our next consultation is in 2 weeks with the tribes, and we'll be doing a specialized focus on public health modernization to ensure that their voice is and their government needs are met. So
Thank you. Thank you, yeah. One of the things we identified was in September, the report that we've commissioned, which we're finding out maybe one of the first anybody's tried to do, is looking at not just return on investment of certain best practices and emerging practices for different communities, but also tying that to what would be the expected health outcomes. How would this change the needle, like in our state indicators? And so that work has been anticipated, but it's not complete, right, to your answer. Like, what is it that we're buying, and what can we expect to get for that? And to be able to be held accountable, not just to the legislature, but also to the boards. The other thing I just want to say is we've tried to be really careful and thoughtful about moving forward. And as I think the consultants pointed out, this is a huge change. We want to identify barriers going forward, and in consultation with communities, really work out how do you get over these barriers? What are the assumptions, and how can we be as explicit and transparent as possible about what managing our expectations, both from the state level, but also the expectations of local governmental services, as well as the expectations of the public. And to do that, that's part of the idea of going forward with this staged approach, and also to have lessons that, and I think Annie called that out on one of her slides, to have lessons that we can then apply. So this level of, I think, change is not linear. We see it as kind of organic, and being able to apply those lessons that we might know in 12, 15 months to going forward for the next stage. So that is the answer to that. And then just your third point, Representative, I think it's really important. How were the criteria picked? These are areas where we feel that you will get the most bang for your buck in meeting the goals of any public health system in terms of its covenant with the people of Oregon.
Can I add one point? Representative Kenny Geyer, one more point that I think is critical as we got this information and reviewed it over the last week. One of the things, although we are not in this report sharing the counties and kind of each county has their own report, but one of the assessments we'll be doing next week in the conversation around the $30 million is we want to be sure there are no counties with huge glaring foundational gaps right now that require immediate triage and response. So that'll be part of the discussion next week as we look at our POP.
Time for another quick question, if there's one. cheat sheet.
Well, I have another question.
Oh. Representative Tengai.
Yay, okay. So, well, my other, I guess, question or also encouragement is, if IP 28 doesn't pass, we're going to be facing a big budget hole. And are you looking at other places in the department to try to pull resources? Conversely, if IP 28 passes and one of the designations is for health, I'm hoping that there's some serious planning being done about how we can make best use of those resources. You're operating in a very resource-constrained environment, and if that were lifted, I recognize there are other barriers, such as workforce and others, in terms of being able to ramp up quickly. But I'm hoping that there is some serious thought going on now, as opposed to waiting to November 9th on that possibility.
Chair Smith, if I may, the Oregon Health, part of the reason we're having phase 2 of policy option package reviews next week, we're having a very intense budgeting process this year internally. To the agency, I would not put myself out as the most popular person in the agency on this day, because we're taking a very, very conservative approach given the cost pressures we're seeing in the Medicaid services, as well as the result of this report, which says there may be some immediate needs that we have to identify and reallocate resources. So we are doing that horizontal look of where funds can be moved across the agency, not just within the 7 divisions of the agency. And we're taking, I think, a very conservative but responsible approach to our budget. And I think you'll see that in the document. But we're in our we're having multiple rounds of conversations about how to be prepared in either event going forward for the state.
So I apologize for the brevity of the discussion, but appreciate the questions and do want to close by handing it back to the floor back to Senator Anderson and Representative Greenlick, our hosts for the day.
Thank you very much, everyone, for taking the time this morning to learn about public health modernization. It's near and dear to my heart, as well as to Representative Greenlick. In closing, it's clear that we really do have important change, an important charge ahead of us to protect the health of everyone in this state. When there's a disaster or a disease outbreak in rural Oregon or in the metro area, Oregon has to be able to respond quickly and effectively. As we look forward to the 2017 legislative session, I'd like to ask my Senate colleagues to support prioritizing an investment in public health modernization so we can deliver on what our constituents deserve, a healthier life within reach. Thanks.
And I'd like to thank